Hello, my name is Steve Bauer. Welcome to the workshop, Take a Breath, Managing Breathing Problems After Transplant. Before we begin, I'd like to thank Sanofi, whose support helped make this workshop possible. It is my pleasure to introduce Dr. Gregory Yanik. Dr. Yanik has been a faculty member in the Blood and Marrow Transplant Program at the University of Michigan since 1992. He is currently a professor in the Blood and Marrow Transplant Program at Mott Children's Hospital. Dr. Yanik has made major contributions in understanding acute and chronic lung injury post-hematopoietic cell transplant. Please join me in welcoming Dr. Yanik.
Well, Steve, thank you, and to everybody out there listening, it's truly a pleasure to be here. As Steve said, I'm Greg Yanik from the University of Michigan. If anybody is from the state of Michigan listening, I'm one of your blood brethren and through, and we're a good group. As Steve said, I've been here for 30 years at the University of Michigan, and much of my focus has been on looking at acute lung injury, chronic lung injury. And what I thought I would do with you today, as listeners, is try to take you into our minds, and try to give you insight that you ordinarily wouldn't have in terms of thinking about the lungs. I'm going to actually teach you a little bit even how to read some of the tests, the pulmonary function tests, and see some of our chest x-rays and walk you some of the things that we as physicians think about. And hopefully this will help click with you and help you as you start thinking things through. By the way, this quote on this first slide, I love this quote. I've used it on several talks now. I think it is the essence of life, the quote from Francis Peabody. The quote's almost 100 years old now, talking about that the real purpose and path to health and healing is to make joyful connections. And thus I want to thank everybody here, everybody at BNT InfoNet for the joyful connections I've made with your team, and for all of you listening today. But I'll start the talk with several other quotes. One of my good friends and colleagues in Seattle at the Fred Hutchinson Cancer Research Center, Guangxing Cheng, she's a pulmonologist there. She actually recently did a focus group with patients in Seattle who had lung problems, lung graft-versus-host disease. And she shared some of the quotes with me. If any of you are listening and you've had graft-versus-host disease of the lungs, I'm sure you can relate to some of these quotes. I need to live to breathe, but I also need to live. I need to breathe to live, but I also need to live to breathe. I'm alive, but I've had so much loss. If I had known I would get lung disease like this, I would rather have died from my AML. What you're hearing in these quotes that Dr. Cheng shared with me, it's quality of life. It's how lung dysfunction, lung problems can impact your quality of life after transplant. Well, hopefully today I'll shed a little light on that, how we can actually predict some of these problems in advance, treat some of them, and help patients' quality of life. If you're going to remember any slide that's going to be a little off the wall for you listening to this talk, it's going to be this slide right here, the third slide of my talk. It's entitled Pneumonia, Lung Disease, and Transplant. Over 50% of patients will develop pneumonia at some point after transplant. Pneumonia can occur at any time, whether in the first few months or many years after transplant. But here's the catch. Not all pneumonias are due to an infection. When you catch pneumonia, you think of having an infection causing the pneumonia. Us as transplanters, now I'm giving you insight into our mind. When we see pneumonia, we don't always see it as an infection. In fact, about half of all pneumonias that we see after transplant aren't infectious at all, with no germs in the lungs. Well, what does that even mean in English? By definition, pneumonia simply means that there is inflammation or irritation in the lungs. For example, if you're going through transplant, you've got fluid in the lungs, some swelling in the lung tissue, irritation of the lung tissue that's making it hard to breathe, that can all be present in the lungs without having an actual infection present. To us, we're still going to call that pneumonia. So start getting into your mind, rethink your mind in terms of that pneumonia just doesn't mean infection. Pneumonia means inflammation in the lungs. It can be infection, but it can mean other things as well. But in reality, though, the lines between an infectious and a non-infectious type of pneumonia are often blurred. And here's what I mean. You can see some chest x-rays here. In fact, I'm going to show you the problems with these chest x-rays in a second. But let's just start with these bullet points. Patients who have an infectious pneumonia, if it goes on long enough, it may lead to a non-infectious pneumonia. Here's what I mean by that. If you have an infection in your lungs that persists long enough, eventually that inflammation from the infection will start turning into scar tissue. And now you'll get scar tissue in the lungs. We'll see that scar tissue on our chest x-ray or CAT scans. To us, we'll still see what looks like pneumonia, but there's no infection in the lungs any longer. The infection's gone. What's present now is scar tissue. So chronic infections in the lungs can actually lead to chronic scar tissue and scarring. To us, it still looks like pneumonia to us, though. On the other hand, flip it around. Patients with non-infectious pneumonia are often chronically infected. If you have scar tissue in your lungs, or if your lungs are weak, this would be the correlate to somebody who has emphysema, for example. That somebody who's been a smoker all their life, for example, has emphysema. They often get infections in their lungs. The same thing can happen after transplant, where you've got some chronic lung injury, let's just say scar tissue again, and that keeps germs in. The germs can't get out. So patients who have chronic scarring, chronic non-infectious types of pneumonia are the same ones who then go on to get infections. The two go hand in hand. Infections lead to non-infectious types of pneumonia and chronic lung problems then lead to more infections. The problem we face as physicians, and this is a sobering one, is we can't even tell which it is by looking at a chest x-ray or a CAT scan. So if you ask transplant physicians to look at these chest x-rays, the ones that the blue arrow is pointing at, and have us as physicians tell you, the patients, which had an infection in their lungs and which didn't, they couldn't tell you, at least with any accuracy, because in many of our situations, these non-infectious pneumonias can look just like an infectious pneumonia. So how can we start all this process? Well, we can start by defining what lung GVH is. What is it? How do we test for it? And how do we treat it? By the way, in case you're curious, what do we often do when we get chest x-rays that are ambiguous and we can't tell if it's an infection or not? We often do what's called bronchoscopy, where we actually will take a periscope and put it into the patient's lungs to look down their lungs, see if what we see, to get a sample of the fluid to see if there's any germs in it or not. But let's start by just defining what lung GVH is. So I'll start with this. It's a form of chronic graft-versus-host disease. It's an obstructive airway disease that usually occurs between 6 to 12 months, but in most patients around a year out from transplant. What it actually means is that air can get into your lungs. It can't get back out. Your lungs are floppy. So you can inhale air, but you don't have that strength in the lung tissue to force that air back out. The air you breathe then gets trapped. It's kind of like stagnant water in a pond. The air gets stagnant in your lungs. Germs set in, chronic infections, infectious pneumonia often then occur. Symptoms in patients with lung GVHD: shortness of breath, chronic cough, just fatigue. It's all those quotes you saw in my first slide that patients will feel, and truly impacts quality of life. It develops in 10 to 20% of all patients with chronic graft-versus-host disease. We've done a lot of studies at the University of Michigan just to look to see how many patients will get lung GVH in general. It's about 5% of all patients who go through an allogeneic bone marrow transplant. Patients who go through an autologous bone marrow transplant, let's say for multiple myeloma or lymphoma, typically won't get this. But our allogeneic transplant recipients, there's about a 5% chance of getting this, quote, lung GVHD. The medical term for it that we as physicians use is called bronchiolitis obliterans syndrome. That's a mouthful. It was probably on the National Spelling Bee to spell it. But if you break down the words, as I will in a couple slides, you'll see that it's simple to figure out. Bronchioles is the smallest airways. Itis means inflammation. So bronchiolitis means inflammation of the smallest airways. Obliterans means they get obliterated, scarred down, fibrosed. So you get inflammation and fibrosis or scarring of the smallest airways in your lungs. This is a syndrome, meaning it occurs after transplant, again in about 5% of patients, where you get this band of scar tissue around the airways. Air can get through that band, it just can't get back out. When I think of lung GVH, and when I think of GVH in general, I often think of a camel with two humps. The first hump is acute graft-versus-host disease. The second hump is chronic graft-versus-host disease. The x-axis here shows time. So the peak onset of acute graft-versus-host disease is in the first 3 months after transplant, where the peak onset of chronic graft-versus-host disease is around a year after transplant. Acute graft-versus-host disease, I always view it like a roaring bonfire. It's in patients. It's just this massive inflammation that patients will get with redness, inflammation, diarrhea, skin rashes, jaundice, all occur with acute GVHD. Chronic graft-versus-host disease, on the other hand, I always view as a series of campfires. The problem is if you get a lot of campfires and they all coalesce, then you get one big fire. So chronic GVH, it comes on slowly. It comes on insidiously. It comes on as a series of patches of campfires here or there, but ultimately it can lead to a lot of chronic inflammation, and chronic inflammation in the body leads to scarring of the skin, or in the case of this talk, in the lungs. So when you see lung GVH is right here, that term bronchiolitis obliterans syndrome, the lung GVH occurs not with acute graft-versus-host disease, but with chronic. You know, there's been a lot of advances made in the past decade in terms of looking at lung GVHD. There have been new diagnostic techniques. I'll show you some of them today. A number of collaborative teams. At the University of Michigan, we're blessed to be in partnership with a number of great medical centers. We're looking at our lung injury work. Centers in Seattle, Stanford, MD Anderson, Emory, in Boston, Dana-Farber. A number of other collaborative teams are also out there now looking at lung problems and lung disorders in transplant. We're looking at things that can predict who's going to get the lung GVH. The best treatment for lung GVH is to prevent it, and then if you start seeing it early, jump on it and get it treated before that fire gets out of control. A number of novel clinical trials are now being developed to treat patients with chronic graft-versus-host disease of the lungs or lung GVH. And then the biggest thing that I'd say has happened over the past decade has been just the support that we've had from a number of organizations like BMT InfoNet and a number of other organizations that have come together to help us in our search and mission to help patients with lung problems after transplant. So this slide here, again, I'm giving you insider trading information into what the lungs actually look like. I like giving talks in person rather than over video, because if I was giving this slide right now in person, I'd be holding up a stalk of grapes. Think of the lungs like a grape stalk. You've got a stalk. The stalk's the airway. The branches off that stalk, which are going to a series of grapes. The grapes, in this case, are air sacs. The air sacs is where air gets transported from inside these air sacs into your body, into the blood vessels that bring air to the body. So literally think of your lungs as just thousands and thousands of these stalks in grapes and hanging off them, each of these grapes being an air sac. And now if you go to this slide, on the far left-hand side right here, you're seeing, just imagine if we took a slice, like slicing through bread, through this grape stalk. You'd cut through a lot of grapes, and you'd also cut through the stalk. So right here, you can't see my pointer, but I put it in yellow, is the air sac. That's called an alveolus. That's where air actually gets into this air sac, and then the air, the oxygen gets transported into the body. This part here, that is in the center, that's the stalk on the grape stalk here. This is a small airway or bronchiole. This is what normally the lungs look like. So if you were to do a biopsy on you or I, this hopefully is what our lungs would look like, with these series of wide open air spaces. The red lines are cells that delineate margins between the various air sacs and grapes in the lungs. But with graft-versus-host disease, what happens is eventually this stalk starts getting thickened, and then the stalk gets so thickened that airway literally starts becoming obliterated, and now air can barely get through, and if it can get through, it definitely cannot get back out. So the left-hand side shows what normally the lungs look like, and then the right-hand side shows what the lungs look like with lung GVHD. At the University of Michigan, we have an extensive database. We recently looked at over 1,000 patients to see who is at risk for getting lung GVH after transplant. And here's a few factors that you should know as patients and caregivers. Patients who had that first hump on the camel, meaning patients who had a history of severe acute graft-versus-host disease, are the ones who are more likely to get chronic graft-versus-host disease. They're also the ones more likely to get chronic graft-versus-host disease in the lungs themselves. It's the second bullet point, though, that I really caution people. Patients who develop a viral infection, and that can even be something as simple as a cold, and or pneumonia within the first 3 months to 100 days after transplant. What happens then is you catch this infection, it can even be a simple cold, your immune system is suppressed. The infection, the germs just kind of sit there. Oh, you feel better at some point, but the infection never truly goes away and just kind of lingers, almost like stewing, simmering, like a fire just simmering on embers or a pot just simmering. And then all of a sudden you get to be a year out from transplant, and that chronic simmering of this infection in the lungs now starts leading to scar tissue in the airways, and now you get lung GVH. So we're particularly in tune at our center for patients who get viral infections in the first 3 months after transplant. And then the last bullet point, it almost goes without saying, but patients who come in with low lung function prior to transplant, measured by a test called pulmonary function test, are the same ones who exit transplant with even worse lung function. Lungs don't get better going through transplant. If anything, they stay stable or get worse. So if you're already coming in low, then those patients are at high risk for getting lung GVHD. So how is lung GVHD diagnosed? Well, there's NIH, National Institute of Health criteria for diagnosing lung GVHD were initially put forth in 2005 by Lisa Filipovich, and then they were modified in 2015 in a Sentinel publication by Madan Jageja at Vanderbilt. But the criteria really require what's called PFTs, or pulmonary function tests. Here's the criteria, the next 2 bullet points. The main criteria is an FEV1 less than 75% predicted for age and size. And the FEV1 must have declined greater than 10% from baseline, meaning prior measurements. Well, if you're listening to this talk, you're probably thinking, what the bleep does that even mean? Well, I'm now giving you insider trading information. When you get your PFTs done, and your transplant physician will pull up your PFT report, it's a big report with a lot of numbers on it. You can rest assured that he or she is quickly scanning that to look for this value right here called FEV1. So what does FEV1 mean? Well, I'll start showing you. Now, most of you have had, hopefully you've had, if you had a transplant pulmonary function test, as one patient described it to me, it's like blowing out your brains. In fact, I decided to go do it myself just so I could see what our patients are going through, and I can appreciate what patients go through. Man, the technologist having to do it just keeps saying blow, 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 blow until I felt like I was going to pass out. I don't know how you as patients can go through the same thing, but it is impressive. So PFTs, the main parameter that we as physicians look at again is called FEV1. FEV1 stands for forced expiratory volume in 1 second. What that means is it's the amount of air, the volume of air that you can forcibly exhale in 1 second. Okay, everybody take a deep breath and blow out as hard as you can. How much air can you actually breathe out in 1 second when you forcibly exhale? So this is what we see as physicians. We'll see a curve that looks like this. This first part right here is just normal breathing. We call it tidal volume. The line goes up and down with every breath you take. That's just air going in and air going out. When you do the pulmonary function test, what we're actually doing is exaggerating your tidal volume. You take those really deep breaths and really forcibly exhale, and now you see this. You take a deep breath, that line goes way up to the top, it reaches a new peak there, and then it goes way down as the technologist gets you to exhale as hard as you can. and then it bottoms out, and then it comes back up again with the next time they ask you to do it. So the FEV1 is the exhaled volume in 1 second. So as you come down that curve, again, if I was in person with you, I could kind of walk you through this with a pointer. But as you come down that curve, right where that FEV1 in red is, we measure how much air do you put out in liters, and now we know it based on your age, your body size, what it should be. We know that for somebody, let's say my age and size, that I should be able to exhale in 1 second over 3 liters of air. If I can only exhale 2 liters, that means that my lung capacity is going to be 67% or predicted. These are the numbers that we as physicians look at. This number is so incredibly key because of the next slide. Early diagnosis of lung GVHD is critical. At our center, we actually went back through, again, 1,000+ patients and looked at all their pulmonary function tests and looked to see how many actually met that NIH definition for lung GVHD. And then we looked to see when the physicians actually picked it up and actually even recognized that the patients met this criteria for lung GVHD, meaning how sick were the patients by the time we saw it and then started treating them for it. Well, there's 3 lines for you here, a green line, a blue line, and a red line. What the green line means is that we picked up the patients when their lung function was between, the FEV1 was between 60 and 75%. Normally to be diagnosed with lung GVH, that FEV1 has to be under 75%. So the green line was we caught patients early. They had just gotten under that 75%. They were in that 60 to 75% range. The blue line are patients that is a survival for patients that we didn't realize they had lung GVH until their FEV1 was 40 to 60%. And then the red line was patients that we didn't realize they had lung GVH until their FEV1 was under 40%. Good heavens. If you're looking at this slide, this is a pretty sobering slide. In fact, at our center, and we look at these things all the time, the median or average FEV1 at the time that our medical team picks up lung GVHD is 57%. That means at a center that's in tune to looking for lung GVH, most of the patients we're seeing are already on the blue line. Why is that critical? Because the horizontal axis here on this blue line is years. It's years of survival, and then % survival. If we can pick up the lung GVH early when you're on the green line, you can see the survival there for those patients is over 90%. We don't pick up the lung GVH until there's so much scar tissue in the lungs that you're on the red line. You can see that the patient's survival there is much lower. So the key for us and for everybody listening to this talk, PFTs are critical because if you do develop GVH in the lungs, you want to make sure that it's caught when you're on the green line. In fact, if you see in your transplant physicians, they say, what did Dr. Yanik talk about? Say, well, if I'm going to get GVH, I want to be on the green line. The problem is we start treating here. When you've got all that inflammation and scar tissue around these bronchioles or airways, well, we need to be treating here when that inflammation is just starting out. Well, to be honest with you, we need to recognize who's at risk here. Literally, at the start of transplant. Guangxing Cheng, my colleague again in Seattle, when she did that focus group that gave the quotes at the beginning of this talk, she actually had a questionnaire. I thought this one was particularly compelling. She had 54 patients that filled out surveys at 3 sites. FHCC is Fred Hutchinson Cancer Center in Seattle, Stanford, and Geneva in Switzerland. She had 30 respondents. And the question was, what aspect of BOS and lung complications after transplant should researchers focus on in order of importance, 1 to 6 being highest priority? Early diagnosis and prevention was number 1. So I would say, hopefully all of you listening to this talk, if you had to rank things, I would rank that really number 1, too. Early diagnosis and prevention should be what we as researchers are focusing on. Picking these patients up before they get a lot of scar tissue in their lungs should be a key for us. Well, all talk should have quotes from Woody Allen. 85% of success is just showing up. So that's my recommendation for monitoring pulmonary function tests. Just get them done. just get your PFTs done. How often should PFTs be performed? Well, in 2020, the National Institute of Health came out with what's called a consensus development project. It was really just an NIH consensus, a panel of experts from around the country doing bone marrow transplant work. And a final recommendation came out for how often should pulmonary function tests be done after transplant. Well, read the 2 bullet points. For those of you that had a transplant, ask yourself right now, are you following these guidelines? Is your physician asking you to follow these guidelines? The guidelines being, have pulmonary function tests done prior to transplant, and then every 3 months for the first year after transplant. For those patients who get chronic graft-versus-host disease, which can be about 40% of patients going through an allogeneic transplant, once the chronic GVHD is diagnosed, obtain pulmonary function tests every 3 months. Even at our own center, that's in tune to looking for lung injury, I find that we often miss having patients meet this NIH recommendations for how often PFTs should be performed. Well, one of the problems is the PFTs themselves. I mentioned that it's like blowing out your brains. For those of you that had PFTs done, it's a tough test to do. So are there alternatives to doing standard pulmonary function tests that we can do that can also tell us that we've got GVH in the lungs? Well, there's 2 things that I'd just like to bring to your attention right now. Here's the first. PFT testing in your hands. This is an NIH-funded study, again, by Guangxing Cheng in Seattle. In here, the patient will perform the PFT testing once a week at home. You could do the testing every day. You could do it every hour if you want to. The device is shown with the young lady holding it up to her mouth on the lower right of this slide. You can see the white part that she inserts in the mouth, and then she blows into it. It's a wireless Bluetooth-enabled device. It's all in that black part that she's holding in her hand. As she breathes out, her exhaled volume, all of her pulmonary function tests are synced with the patient's smartphone. So if you have an iPhone or Android, you can actually see what your pulmonary function tests are. You can see your FEV1. And now that if you're listening to this talk, you actually know that an FEV1 is the forcible exhaled volume of air in 1 second, and you know it should be over 75%. Well, now you can actually see it. Say, geez, I'm now down to 65%. What happened? Imagine if you could do that in your own home without having to get these PFTs done. Imagine if you could see the result yourself. But better yet, this device not only allows you to see it, we see it as physicians. And I've got a coordinator whose sole job right now at our center, her name is Maria. She'll contact me. Hey, Dr. Yanik. Hey, Greg. My first name's Greg. Mr. Jones, Mr. Smith, just had a 10% drop in their FEV1. Should we bring them in to be seen? Should we contact your other colleague that's seeing them next week? Meaning that these readings will come to us in real time whenever you do them. There's right now a large 4-center study in progress being done in Seattle, Stanford, MD Anderson, and at the University of Michigan. We're actually looking at getting these devices from a foundation so that we can actually give them out to patients to start using, to start giving them training on how to do it. I think it can be a really powerful tool that you can have in your own hand so that you can measure your lung volume and your lung function. There's also what I wanted to share with you, new CAT scan, CT stands for CAT scan, technology. It's called PRM. PRM stands for parametric response mapping. It's just a term. This technology was developed at our center at the University of Michigan. But what it really does is it color codes the lungs so that you can see the areas of lung damage within the lungs themselves. So if you've ever seen a CAT scan, they're black and white. You see areas that are, air is normally black on a CAT scan, white are areas where you've got some type of thickening of tissue or pneumonia or something. Well, in our CAT scan technology called PRM at our center, we actually will take the lungs, we'll divide the lungs into various segments, various cubic segments called voxels, Well, look at the density of each of those segments when a patient takes a deep breath, when they exhale. And then we know what's normal, we know what's abnormal, we know what we see with scar tissue, we know what we see with lung GVH, and we color code everything. And now we can actually count it up even. We can quantitate it and say, hey, out of every 1,000 cubes that we're looking at, 800 of them already have changes of lung GVH. And we can follow that with treatment on CAT scans. What you're seeing here, where it says 1 year post-BMT, this is one of our patients. It was a 30-year-old male who had some mild lung symptoms, a little bit of shortness of breath, fatigue. We did pulmonary function tests on him and a CAT scan, and they're both read as normal. We put the CAT scan through this PRM color coding, and now you can see all these different colors. What do the colors mean? Well, green is normal. Yellow starts showing areas of air trapping where lung GVH sets in. Purple starts showing areas of thickened lungs where you can start getting scar tissue. Even though his pulmonary function tests and CAT scan were both read as normal, when we did this color coding, his lungs were anything but normal. We then, 2 years after transplant, by the time that the pulmonary function test actually got under 75% FEV1, now the patient was diagnosed with lung GVH, we repeated the CAT scan. His lungs are mostly yellow now. Red on the CAT scan means that you've really got severe air trapping, almost like emphysematous changes in the lungs going on. And this is the one the pulmonary function test just picked up, that there could be lung GVHD. Here we're seeing a ton of yellow. And then 5 years after transplant, now these lungs were all yellow, a lot of red. Ultimately, this patient underwent a lung transplant itself just because the lungs weren't salvageable with any of our other therapies. Now, this tool, it's a powerful tool. It's being studied in a research study. I gave this talk to another group several months ago, and within a week or two after giving the talk, I started getting all these emails from folks around the country. How can I get this done? The technology is available at other centers. I can walk your physicians through some of it, how to get it done. But right now, it's primarily being done as a research study to validate its utility at 4 sites: University of Michigan in Ann Arbor, Michigan, Seattle, Stanford, and at MD Anderson. We're also bringing in Emory in Atlanta and Dana-Farber Cancer Center in Boston to partner with us to validate how well this technology works. How about the therapy for lung GVHD? Well, there's a few randomized clinical trials, sadly enough, and most of the trials that have been out there involve 20 patients, maybe 30 patients, not large numbers. There have been 2 trials that have truly impacted care that I would say. One is a trial done by Anne Bergeron in Paris. It was published several years ago, looking at inhaled steroids. So these would be the inhalers that you use that have steroids in them. The steroids to help coat the lung tissue that's been irritated and inflamed from the GVH. The other one stands for FAM therapy, that another one of my good friends, Kirsten Williams, Kirsten is down in Atlanta at Emory, published back in 2016. And I'd say FAM therapy has become kind of the gold standard for the initial therapy for lung GVH. The F stands for inhaled fluticasone. That's an inhaled steroid, kind of like what Dr. Bergeron was using in their inhaled steroids. A stands for azithromycin. It's actually azithromycin or azithromax. It's actually an oral antibiotic, but it's also an anti-inflammatory agent that helps take down inflammation in the lungs. The M is called montelukast. All these drugs, azithromycin and montelukast, are oral. The other name for montelukast is Singulair. This is a powerful anti-inflammatory agent often used in patients with asthma. So we took a lot of the asthma therapy and developed this FAM type approach that Dr. Williams piloted. And I'd say that FAM therapy has now become pretty much the gold standard, especially for patients with newly diagnosed lung GVH. If you go to clinicaltrials.gov, this is the FDA's website for what's being done right now. You'll see a number of studies out there. A colleague of mine is just starting from the far right where it says Avelostat. Steve Pavletich at the NIH has this novel drug called Avelostat for treating lung GVH. Based on impacting enzymes that bring in neutrophils into the lungs. Neutrophils can cause, it's a blood cell that can cause lung damage. Itacitinib by Amin Alusi at MD Anderson, another good friend. Itacitinib it's almost like ruxolitinib or Jakafi, if you're aware of these drugs as immune suppressant drugs for the lungs. Pirfenidone, Joe Su, another friend at Stanford, has been piloting, and he's got funding to study it. This is a drug that breaks down scar tissue, so this could be a wonderful drug if the studies pan out in lung GVH. A group in Switzerland has now piloted liposomal CSA, stands for cyclosporin. Cyclosporin is like tacrolimus, and it's an immune suppressant drug that you would inhale, literally, into your lungs if you had lung GVH. Kristen Hawk also has a drug called nintedanib. Cass Myers in Cincinnati, Zach D. Philippe are looking at a drug called ruxolitinib or Jakafi to treat lung GVH. And then Corey Cutler up in Boston at Dana-Farber has now got NIH funding to study a drug called belumosudil or Rezurock for patients with lung GVHD. This is it, though. As of a few months ago, these are all the trials that are out there for lung GVHD being done. There need to be a lot more. Then just my last few slides, I just want to show you this. The power of exercise. I can't understate this slide enough, or I guess overstate it maybe. The power of exercise. This is the actual PFT report that we as physicians see. Remember I said there's all these values on there, and what do we look at? Well, this is a 50-year-old male at our center with chronic graft-versus-host disease. And the top red box is where the FEV1 is. It says percent pred, percent predicted. That meant that his forced exhaled volume in 1 second was only 52% of normal. Again, anything under 75% means you've got lung GVH. The bottom red box is one value I haven't told you. It's DLCO. DLCO, it's a fancy medical term for how well air or oxygen that you inhale can actually get through your lungs and into your bloodstream. For example, if your lungs are all scarred down, then the air you breathe can't get through the lungs. But what if the lungs are healthy, but your blood vessels, we'll say from atherosclerosis or other blood vessel damage, are all thickened and the air can't get into them? So the DLCO can be low in patients, whether if you have lung problems or if you have blood vessel problems. So it's one thing to have a low FEV1, but you also want to look at what's called the DLCO. And here's how I'm showing the slide. Again, the DLCO measures your ability to transport air into the bloodstream. So when this patient, his first initial is T, so when T was developed lung GVH, he started bike riding. This was his pre-bike riding pulmonary function test. He had an FEV1 of 58% and this DLCO, the D stands for diffusion, so just this diffusion parameter of 77%. That means 70% of the air he was able to take in was able to get into the bloodstream compared to predicted for his age and size. How would I feel? How would you feel if you had that? Probably tired, short of breath. So he took up bike riding. I was always amazed that somebody with an FEV1 of 58% could ride 20 miles, 30 miles, sometimes 40 miles a day, and he did it religiously. So he's been doing it for many years now, and I recently did follow-up pulmonary function tests on him. And after years of bike riding, his FEV1 hasn't gone up at all. In fact, it's gone down. But his diffusion number, this DLCO, has gone up to 107%. So he couldn't get rid of the scar tissue in his lungs, but he made his blood vessels so dang healthy that every molecule of oxygen he breathes in gets across into his body. He feels great, mostly because he's exercised himself to the point of incredible health, maximizing his lung health, but really maximizing his blood vessel health. And thus, the power of exercise for all of you who've got chronic graft-versus-host disease, who've had lung GVHD, I can't overstate it enough, as evidenced by this patient. I smile every time I see him because he's my poster child for goodness. Still riding 20, 30, 40 miles a day on a bike. Amazing. From one of our, if you've ever read the book, it's a great book, The Boy, the Mole, the Fox, and the Horse by Charles Mackesy. It's a great quote there. It's a boy who's walking across through the woods and across the terrain with a horse, obviously with a mole and a fox too, and he looks up to the horse and he says, "What's the bravest thing you've ever said?" asked the boy. "And help," said the horse. Well, I just want all of you that are listening to this talk know that it's really a circle of help. It's a circle of hope. And that it's a help that we all need to give hope. We as clinicians need help from you, the patients, to enroll on clinical trials to treat lung GVH. The researchers in our labs, our centers across the country, need us as clinicians to come up with ideas, to bring them patient samples and things that they can then study in their labs to look at lung complications. And then ultimately, what the researchers develop then comes back to the patients. They're asking us for help. It's a circle of help. It's a circle of hope. And thus, "What's the bravest thing you've ever said?" asked the boy. "Help," said the horse. That's a tough thing, but I think each of us who are going through this to recognize that saying help is sometimes the wisest thing to do. And with that, I just want to conclude by thanking everybody here that listened to this talk today, to the BMT InfoNet, to the patients we serve. And I'm truly grateful and blessed to be able to be part of the lives and the care of those that I work with. I truly feel honored. I have the greatest job in the world. But I want to thank the medical teams I work with, and I want to thank all of you. I just want to end with a quote. "Happy are those who dream dreams and have paid the price to make them come true." For those of you that have gone through a bone marrow transplant, you've paid a price. I just hope that you still have your dreams and that we as researchers can help you fulfill them. By the way, the picture on the far right-hand side is not anybody who's gone through transplant. It's my son and his granddaughter. That's my first grandchild. I figure any talk that I can show off my granddaughter is a good excuse for me to show a picture of my cute granddaughter. So with that, thank you, and I'll take any questions.
Thank you, Dr. Yanik, for this excellent presentation. We will now begin the question and answer session. If you have a question for Dr. Yanik, please use the chat box on the left side of the screen to submit your question. We'll answer as many questions as possible. Our first question is, how useful is belismodil in a person who has lung GVHD for 7 years? Any chance of improvement or only stability?
A great question. And one of the questions that you can also be is, how do we measure response? How do we define success? The large belumosudil trial that was published in patients that had lung GVHD found that it only helped the numbers with approximately 16% of patients. That may sound sobering, but to be honest with you, every one of us recognizes that it's a good drug. We just have to use it early. The key for us are those getting PFTs done on patients, or those handheld spirometry, or that CAT scan with that PRM, or other techniques to diagnose that these patients' lungs are starting to get sick, and we need to treat early. So thus, if you're going to hope for improvement with belumosudil, the key is to use it early. When you've already got established lung GVHD, then the responses are more likely going to be stability, meaning that your PFTs didn't get worse. Your FEV1 was 50%, and instead of going from 50 to 45 to 40 to 35%, drugs like belumosudil kept it at 50%. That would be a marker for success. So there are a number of drugs out there that we're looking at. You saw some of them in that one slide: belumosudil, ruxolitinib, itacitinib, pirfenidone. I think the key for all those drugs is early use and early intervention before you get too much scar tissue in the lungs. Once you've got a lot of scar tissue, think of lung GVHD. In fact, I didn't talk about this, but I could have. Maybe if I gave this talk again, I would. Think of lung GVHD as two stages. The first stage being inflammation. The second stage being scar tissue. The drugs that we use to treat inflammation are different than the drugs we use to treat scar tissue. So drugs like belumosudil and ruxolitinib and some of the other ones, itacitinib that I mentioned, they're going to focus a lot on decreasing lung inflammation. But once you get the scar tissue, then those drugs hopefully will just help things keep stable, but they may not give you improvement. Now, one drug I mentioned, pirfenidone, that was being studied at Stanford, that's a drug that's looking at scar tissue. That drug may actually be in that, focusing on the second stage of development when you get that scar tissue. So to make a short answer long here, I would say if you've already got lung GVHD and you're using a drug like belumosudil or some of the other agents we use, disease stability, just keeping a stable FEV1 is what we really look at.
Okay, thank you. Next question is, how often should someone have PFTs if they have not been diagnosed with GVHD? Should people who have had TBI have more frequent PFTs? If so, how frequent?
That is a great question. I'd almost like to have the person in front of me to ask them how often have they had PFTs done right now. By the NIH recommendations, the PFTs should be done in fact, can I go back on the slides? Do I have that ability to go backwards?
Yes, previous.
Right there. All right. So it says, how often should PFTs be performed? This question gets to a hole in my slide here. I said PFTs should be performed every 3 months or the first year after transplant. I didn't say what should be done after that. So at our center, we recommend that PFTs be performed at 18 months, so once you're a year out, then get PFTs at 18 months and 24 months after transplant, and then once a year through year 5. And that's what I recommend right now. So every three months for the first year, and every 6 months in that second year, and then once a year for years 3, 4, and 5 out from transplant. And that's my typical recommendation. Once the chronic graft-versus-host disease has been diagnosed, and PFTs every 3 months. How long do you go with every 3 months? Well, it kind of depends on the patient. Certainly for the first year or more after they're diagnosed, you should follow it. With patients, once they get chronic GVHD, the median time or the average time it takes to getting lung GVH or the lung manifestation of that is usually about 6 to 12 months later. So that first year from diagnosis of chronic GVHD is critical to keep following PFTs. But to answer the question, for patients who never get chronic GVHD, I recommend PFTs every 3 months for the first year, every 6 months for the second year, and then once a year for years 3, 4, and 5 after transplant.
Okay. I have chronic cough and frequent bronchitis, still 3 years after an autologous SCT. My chest x-ray is usually okay. What do you recommend next?
That's a good question. So this is an autologous transplant. We recently published, at least it was published in abstract form, that patients who have had autologous transplants, especially patients who've had them for lymphoma, have nearly a 20% incidence of getting some lung complications after that autologous transplant. And sometimes these lung complications can last for a long term. I would actually, to the person who wrote the question, I actually would almost treat you as if we'd treat a lung GVH patient. And I would say that you could be a good candidate for FAM therapy, that fluticasone, azithromycin, and montelukast, if you haven't been on it already. So the F for FAM is fluticasone. That's an inhaled steroid, so it's an inhaler that has steroids in it. It's different than some of the other inhalants that people take for asthma. And then the A, the azithromycin, is an anti-inflammatory antibiotic, and then the M for montelukast is an anti-inflammatory agent. I consider that, and just knowing, and very few transplant physicians even realize that roughly 20% of patients who get an autologous transplant can get some significant, almost chronic lung complications after that. If you've had radiation of the chest or lungs, that's the really high-risk group for who's going to get these chronic lung complications. So if the person writing the question had, let's say, lymphoma, and they had radiation to their chest that would hit the lungs and then they had a transplant, that's a high-risk group for having chronic lung damage, scarring. I definitely would consider them probably, if they're still symptomatic, at least for that FAM-type therapy.
Thank you. Will the flu cause lung GVHD to flare up?
We're looking at that. So, I stated that patients who get viral infections, upper respiratory infections in the first 3 months after transplant have a higher risk for getting lung GVH, 12 months later. We started looking at patients who had lung GVH. If they get a flu, what happens to their lung GVH? Does it all of a sudden get worse? We're not sure of that answer yet, but we're looking at a number of studies that are being done to look at this right now. I will admit, patients who do get influenza who have lung GVH, we typically, at least I will, treat them a little longer than I treat somebody normally for influenza. I also make sure one of the key factors in treating lung GVH, for those listening, is a blood test called IgG. IgG is your antibody level. And if you have chronic GVHD, it really would behoove your transplant physician when they not only to get a CBC on you when you come into clinic, but to get an IgG level. Patients who have low levels of IgG or antibody in their bloodstream are the ones who get these chronic infections. If you can keep that IgG level up, at our center we have every center has their own cutoff, but our center is 400. If you can keep that IgG level up over 400, then you can cut down the number of lung infections or the severity of them. So for the person who asked the question, if they already have chronic GVH or if they already have lung GVH and they get influenza, we're studying whether that will cause the lung GVH to worsen. We haven't seen that yet, but we're definitely wary of it. But what I really recommend in those patients is make sure you keep your IgG antibody level, it's a blood test, up to prevent those lungs from getting worse.
Thank you. If a child has GVHD in lung and treated and subsided, could there be a change as an adult it could return?
Say the question one more time, Steve.
If a child has GVHD in lung and was treated and it subsided, could there be a change as an adult that it could return?
That's a really interesting question, and you could take away the child part and just say, if any patient had developed lung GVHD and you got better with treatment, you had early recognition and you treated and it got better, could it come back, let's say 10, 20 years later? In my own experience, that'd be highly unlikely. So in this question, let's say you had a 5-year-old child who had lung GVH and now they're 35, should they worry about the lung GVH coming back? I haven't seen that, and I've been here at U of M for 30 years, so I've now been able to follow patients for a long time. But what I will admit is, as a child with GVH gets older, keeping them away from other lung irritants is key. Smoking, marijuana, any inhaled agent that vaping in particular, vaping almost causes I always view it like rock crystallization of the lungs with vaping. So anything that you're going to smoke or inhale that could cause further irritation to the lungs as you get older, maybe the GVH won't come back, but you've already got lungs that let's say at 5 years old, the lungs had GVH, you've got some scar tissue there. And then if you keep adding more lung damage to them, you could worsen your lung function. The beauty of kids is that lungs continue to, as they grow, their lungs will expand and grow too. So kids stand a better chance of getting through the side effects of lung GVH, at least young kids, than does somebody who's 40 or 50, whose lungs obviously aren't growing anymore. So the short answer, I haven't seen that lung GVH at your age 5 comes back at age 35, but I do worry about other things that could worsen lung GVH. That could worsen, the lungs, like smoking, cigarette smoking, marijuana, vaping, things like that.
Okay. This will have to be our last question. We are running out of time. I am 18 months post-transplant and still need oxygen at night. Can I recover?
And by the way, Steve, everybody asking these questions, these are some of best questions I've had asked of me in several years, I think. So I just appreciate the thoughtfulness of the questions. I mean, this question here, it's a heartfelt question. To answer your question, I need to see your PFTs. If your FEV1 is 20-30%, it's unlikely that your FEV1 can ever come back up to 40, 50, 60%. If your FEV1 though is at 50, 60%, there have been some trials that have improved lung function. We were part of a trial with a drug called etanercept years ago. Ken Cook and I, who's at Hopkins, we actually did see in about a third of our patients the drug etanercept did help lung function in patients with lung GVH. But it really helped those patients whose lungs weren't that severe. If your FEV1, if you're on oxygen and your lungs are already in that 20-30% range on that PFT, you're just hoping for stability. I can't promise you that there's a drug out there that'll be a magic bullet that get that FEV1 up to 40, 50, 60% or higher. If you're at 50, 60, 70% and you're asking this question, then I'd say that there's a chance. It really comes down to, think of those two stages I said. The first stage is inflammation, where you just have to put out the fire. The second stage is scar tissue, where now the fire is gone and you're left with scar tissue. If you're at the point where you're left with scar tissue, it's hard to recover a lot of lung function. So I guess go back, ask your transplant physician, say, what's my FEV1? Well, he or she will look up at you and think, how do you know about this term? Because you've heard with this talk today a lot of insider trading information. And sit down and ask your transplant physician seriously, can I see my PFTs and what my FEV1 is and what the trajectory is? If the trajectory of your FEV1 is that it's stable, let's say it's been holding at 30%, that's good. But if it's going 75, 60, 50, 40, 30, 25, that's not good, and that's a really worrisome sign to me that the trajectory continues to decline.
Thank you. On behalf of BMT InfoNet and our partners, I'd like to thank Dr. Yanik for this very helpful remarks on our questions. And thank you, the audience, for your excellent questions. Please contact BMT InfoNet if we can help you in any way. Enjoy the rest of the symposium.